almost 25 years that I'm in the field of medical physics, and I was working for 23 years in Switzerland, in Bellinzona, in a small center. It is called now Oncology Institute of Southern Switzerland. And now, at the beginning of this 2015, I joined the Humanitas Institute in Milano, in Italy. I was working since many years already with the Humanitas institution, so that's why it was a natural move of my life and my professional. It's a problem, the contouring for VMAT and for whichever intensity modulated techniques where the inverse planning optimizer plays a role. The big point is the translation we have to make to properly instruct the optimizer to give us the proper plan for each patient. This means that the accuracy and the precision of the contouring has to be as much as possible. The quality of our contouring has to be as precise as possible, because it is a mathematical process that will take into account this kind of contouring, not knowing anything about the clinics. So what is the key point is to precisely contour and make the delineation of all the organs at risk and target volumes. So it is just a matter of precision and accuracy. And in this sense, it is very important to follow possibly some guidelines. There are many atlas on the web. There are many possibilities to find good guidelines to delineate properly the organs at risk, especially. For what is the target volume, it is the clinical side has to fully understand what we want, what we have to treat for the patient. So to properly and precisely make the contouring of exactly the region we want to irradiate to a certain dose level. So it is a matter of accuracy and precision because of the 2 points. One, the mathematical process of the inverse planning. On the other side, we have to be precise of the treatment itself. I would say that VMAT is a great tool to be used, a technology that can be used for all the sites in the radiotherapy field. All the sites, despite of the size of the volume, the location, so in principle we can really use the VMAT for whichever site we want. From the small metastasis, single metastasis, to multiple metastasis, to very huge volume like I have in mind the most complex case, the total marrow irradiation. So everything can be done in the same way, with the same technology, with the same stuff. So the versatility of the VMAT technology is a great point, because it is really opening a wide view of many different treatments that are at the top level for all our patients, all our sites. Even, for example, in the palliative direction, it is something that we can improve. If we can be if you can use a good technology with homogeneous dose in the target and sparing especially the critical structures, the sparing of the critical structure can lower the morbidity of the patient, and we can even have a gain in terms of quality of life, and the hospitalization of those patients may be due to the radiotherapy toxicity that can be strongly lower. So also in the field of the palliative cases, we can have a big improvement in the health as a whole. SBRT could be challenging in terms of breathing, or can have difficulties, can give difficulties to the patient for breathing. So the free breathing is definitely much more comfortable for the patient. Using the 4D CT, we can have the ITV delineation that takes into account the movement of the tumor volume. So in this way, we can consider and take properly into consideration all the geometrical aspects of the movement of the target. In this way, I would not use personally the gating for the lung patients, because this could be giving you an interrupted treatment too many times during the treatment, and this is prolonging the time of the treatment. Gating could be, on the other side, considered just to be sure that the movement of the volume, of the target volume, is staying just within a certain threshold that is coming from the 4D acquisition. Just to avoid that during the treatment, the patient is taking a completely different breath. In this way, in this case, we can gate, just to be sure that during the breathing is constant as expected from the planning point of view. It is something different. So if a center is equipped with the LINAC is there. And if it is equipped with the VMAT, VMAT is there and available and doable, while the brachytherapy is something that is not for all the centers. And I'm pretty convinced that the brachytherapy has to be used only from really experienced people, because it is much more complicated than what could be a planning and the treatment with VMAT. So in principle, I would say that there is space and for the two technologies together, keeping the centers with the technology and the expertise they have. In our professions, there is really a gap sometimes between clinics and the technology. The technology is advancing very fastly, and we can follow with the technology really those advances in the practice. The point is that sometimes the clinics and the clinical results in terms of toxicity, in terms of biology, in terms of understanding what we should do or what we should modify to properly account for all the possibilities of the technology, sometimes it is not fast enough. In this respect, I think that the great point we have to follow on the physics side and on the clinic side is to put all our brains together and find to work together, work in a sense of knowing what the technology can give and knowing on the other side what the clinics needs. Only in this way we can join the two perspectives and have the maximizing the benefit, trying to use as maximum as we can the technology, trying to have all the benefits in the clinical perspective, knowing what the clinical needs are. So only joining together the two professionals we can make a good job for the patient. Photos for breakfast,
Okay,
I like.
This is the title, and we have a dessert.
Wow,
For you.
great.